next speaker will be Matt Mendelsohn, who'll be speaking on perioperative management of anticoagulated patients with cardiac comorbidities undergoing sinonasal surgery, an American Rhinologic Society survey and recommendations.
Quite the long title there. May need to work on revising that. But today I'll be talking about what Dr. Vinciano just mentioned, a survey study that I worked on with Dr. Tong from Lenox Hill. So here's our agenda today, a little bit of background on the antithrombotic medications, the survey overview and the results, and then some of the current guidelines that exist. So you are a practicing rhinologist, and one of your patients has chronic rhinosinusitis with polyposis that's refractory to maximal medical management and is interested in surgery. Patient's a 61-year-old male with a history of atrial fibrillation on Eliquis. How will you decide to manage this patient with regards to their Eliquis? Do you hold it? Do you continue it? How do you make that decision? So a little bit of background, the perioperative management of antiplatelet and anticoagulant therapy is a critical consideration in sinus surgery, given the balance between minimizing bleeding risks and preventing thrombotic events. Continuation can lead to intraoperative bleeding, hemodynamic instability, returns to the OR for epistaxis, whereas discontinuation can lead to ACS, including an NSTEMI and a STEMI, a CVA, DVTs, and pulmonary embolism. There are also some unique considerations within sinus surgery. There's the delicate manipulation of highly vascularized tissues, such as nasal mucosa, ethmoid sinus walls, surrounding structures. The majority of rhinologic surgery is ambulatory, which can prevent the ability to monitor patients postoperatively for complications. And this is also characterized by an open mucosal wound that is left to heal by secondary intention versus most standard surgery. So the goal of our study was to highlight how ARS members currently manage antithrombotic medications, provide an overview of the latest antithrombotic treatments as well as their appropriate usage, and then our goal is to work to develop a comprehensive guidelines for the perioperative management of these medications within rhinology-based surgery. So just a little bit of background, there are antiplatelets and anticoagulants within antithrombotic medications. You have the antiplatelets such as COX-1 inhibitors like aspirin, the P2Y12 inhibitors like Plavix, and then the anticoagulants including warfarin, heparins, and the DOACs. So our survey was a 59-question cross-sectional survey that was designed in conjunction with a vascular cardiology specialist at Lenox Hill. It was distributed to all members of ARS, and then we tabulated our results. So we had overall 98 respondents. There were around, this email was sent out to about 1,100 members, which is about a 9% response rate. And of those 1,100 members, there were around 600 who actually opened our email. So that brings us up to more of a 14% respond rate. Here's a little bit of kind of the background of our respondents. So the majority of our respondents were in practice for over 10 years. They practiced in an academic or teaching hospital, and they performed around 100 to 200 procedures annually. When it came to whether or not they decided to hold or continue this medication, we can see that the majority of our respondents held the medication regardless of the class, with the lowest amount being within aspirin, with only 72% holding the medication. Now, when we talk specifically about aspirin, how did they make this decision? Did they base this on the primary care physician, the cardiologist, on their own experience, or based upon blood loss findings during their case? And we see that for aspirin, the majority of those who held the medication did this purely based on their own experience, as well as when deciding to restart the medication, did this on their own experience. For those who continued the medication, again, we see that they just based this on their own experience. When it came to the Plavix or the P2Y12 inhibitors, the majority of our respondents based their decision on the cardiologist, but we can see that that 32% did this on their own experience as well, and 25% for those who continued the medication. Moving on to heparins, again, we see a similar trend that the majority of our respondents based this on the cardiologist on when to hold it as well as to continue the medication. And then with warfarin, once again, we see that the majority really based this on the cardiologist. And lastly, with the DOACs, we see that those who continued it, all who decided to continue the medication, based this on the cardiologist versus those who held the medication, some based on their own experience or on the PCP, but again, mainly based upon the cardiologist. And so in terms of complications, the overall complication rate was quite low, but the highest complication rate was within those who decided to continue aspirin, which had 15% of complications, which included those listed before and bleeding, return to the OR. Now, how soon before surgery do you hold the medication? When do you decide to restart the medication? Here we look at the antiplatelet medication, specifically aspirin and the P2Y12 inhibitors. We can see the majority of respondents held this medication 5 to 7 days before the procedure and then restarted on a postoperative day 2 to 5. But we can clearly see that this is quite heterogeneous. We see that 21% restarted at postoperative day 1, 21% restarted at postoperative day 5 to 7, and 22% restarted at greater than postoperative day 7. So in no way is there a consensus among our survey respondents. In terms of the P2Y12, we see that the majority held the medication 2 to 5 days before and then restarted it on postoperative day 2 to 5. Moving on to the anticoagulants, we came to heparin. Majority of our respondents held this 5 to 7 days before and then restarted on postoperative day 2 to 5. And then for both warfarin and the DOACs, most held the medication 2 to 5 days before and restarted it on postoperative day 2 to 5 range. So there are some current guidelines that exist. The American College of Chest Physicians developed a clinical practice guidelines in 2022 for the perioperative management of antithrombotic therapy. The guideline really looks into 4 specific categories: warfarin, those who are receiving warfarin, the use of heparin bridging, the DOACs, and then antiplatelet medications. They provided a suggested risk stratification system for patient-specific periprocedural thromboembolism risk, which they separate into high, medium, and low, and then procedural bleeding risk, which is based upon the International Society on Thrombosis and Hemostasis guideline statements. However, sinus surgery was not listed within any of these categories. Here we can see the chest guidelines risk stratification between high, medium, moderate, and low, which they look at things such as the presence of mechanical heart valve, if they have atrial fibrillation, looking at CHA2DS2-VASc scores, and then history of VTE as well as thrombophilia. When it comes to the bleeding risk of a procedure, again, high, low to moderate, and minimal. High being procedures such as orthopedic surgery, major thoracic surgery, low to moderate being lymph node biopsies, GI endoscopies, and then minimal being more like ophthalmologic and dermatologic procedures. Based upon their evidence, they developed some antithrombotic patient care pathways, which we're now going to compare to our survey respondents. So the chest guidelines, when it came to aspirin, recommended to continue this medication perioperatively, regardless of the bleeding risk in surgery, whereas the majority of our respondents held this medication 5 to 7 days before and then restarted it on postoperative day 2 to 5. When I say the majority, again, this was only 55% of our respondents, as well as restarting it, this was 36% of our respondents, but we can see that these do not align. Moving on to warfarin, for minimal risk surgery, they recommended to continue the medication perioperatively, whereas for mild to moderate or high risk, to hold the medication 5 to 7 days before with a Lovenox bridge 3 days before surgery, and then to restart warfarin the evening of the procedure with a Lovenox bridge beginning on postoperative day 1. In our survey, the majority of respondents held this medication 2 to 5 days before and then restarted it on postoperative day 2 to 5. And then lastly, in terms of the DOACs, the chest guidelines recommended holding these medications 2 days before surgery and then restarting it 24 hours after surgery for low-risk procedures and 48 to 72 hours for higher-risk procedures, where in our survey, the majority held this medications 2 to 5 days before and then restarted it on 2 to 5 days before. And there were no complications within this category. So a few limitations to this study. This was a survey study. We were unable to really talk about specific heparin bridging. This was not really included in our study, in our survey questionnaire. We also had a low number of respondents. We had 98 total respondents. And then in terms of some of the conclusions and future directions, so this survey really highlights that there's significant variability in the perioperative management of antithrombotic therapy in sinus surgery, with many surgeons relying on the clinical experience as well as the cardiologist's recommendations in the absence of any standardized guidelines. Given the complexity of managing these medications, there's a clear need for an evidence-based guidelines to help rhinologists navigate the balance between minimizing bleeding risks and preventing thromboembolic events. And so future research should focus on developing consensus recommendations, and standardizing these practices will enhance patient safety and outcomes while reducing complications associated with both bleeding and thrombosis. And thank you. Here are my references. Dr. Plum?
okay for the rhinologist to say, you're absolutely fine, we'll stop it, and then you can restart. If somebody has AFib, is more complicated, you probably medical legally should be having the cardiologist weigh in that case.
Thank you. Agree.
That's a great, it's a really interesting question. It's lots of food for thought. So I think you and I were talking about this one day, your study. Did you, and if you did, forgive me for missing this, was there any evidence you could glean from your survey about whether any of the rhinologists who responded, you said this was based on their experience, right? Like how they made decisions. Did anyone comment about having had a patient have a thromboembolic complication because they'd made a decision to hold? Because it's this push and pull, right? Which complication is something that you or the patient can tolerate most? And what's the kind of discussion in terms of like shared decision making that you sense is going on when people are having these conversations about guidance on stopping?
Yeah, we did have a few of our respondents say that there was in fact a complication from holding these medications, which included either a pulmonary embolism, a DVT.
Yeah.
It was not specified specifically which one, but they did have a thromboembolic event. In terms of the conversations, I mean, you know, even being a resident, I've had an attending ask me to call the cardiologist before, like right before the surgery, because the patient hadn't stopped their medication, and just speak with them to give their advice. And oftentimes it's a push and pull, being, you know, well, it'd be good to hold it if you can, but there's never really such a definitive, yes, this patient needs to stop it, or they need to restart it on this day. And so I think having something more formalized will help answer those questions and help facilitate those conversations. All right, thank you.
Zoom. Just quick, any questions from the Zoom audience also?